obstructive sleep apnea. Professor Khalid is an instructor of medicine at Harvard Medical School, associate professor at medicine at Tufts Medical School, joint appointment in pulmonary critical care and division of sleep and circadian disorders medicine at Brigham and Women's Hospital, ambulatory medical director, pulmonary division, Brigham and Women's Hospital, medical director, non-invasive ventilation clinic, Brigham and Women's Hospital. Assalamu alaikum. Professor Khalid, assalamu alaikum. Sound, صوت. Can you hear me, Professor Khalid?
معنا يا دكتور.
Yes, I can. Yes, I can. Can you hear me?
دكتور خالد.
أيوة سامعك.
Good afternoon.
Good afternoon.
I am Professor Tageldin. We appreciate very much your participations in our Congress, and I am sure that you'll contribute with your excellent presentation during this Congress. Please, can you start, please?
Okay, sure. Can you see my slides?
Excuse me?
I'm sorry?
Can you see? شايفين السلايدز بتاعتي?
Yes.
Okay, can you hear me well?
The slides.
Yes, we are ready.
No, doctor.
Can you hear me?
We can see the shared screen.
Doctor, can you please share screen with us? Yes, it's okay. It has been shared.
Okay, can you hear me too?
Yes, we can hear you fine. Thank you.
And you can see me?
Assalamu alaikum.
عليكم السلام. السلام عليكم. انا يشرفني ان انا اكون معاكم النهارده طبعا. انا خالد اسماعيل، خريج جامعه اسكندريه 95 وهنا في امريكا من سنه 98. يعني خلصت طبعا الفيلوشيبس internal medicine residency وبعدين pulmonary critical care fellowship. بعدين اشتغلت في Tufts Medical School, Tufts Medical Center, وبعدين Harvard Medical School, Brigham and Women's, Mass General Hospital now. بقالي يعني يمكن 7-8 سنين معاهم. Can you hear me well?
Yes, we can hear you well, Professor Khalid.
Perfect. Okay, so I have no disclosures, and today I'm hoping to just go over a brief, overview of obstructive sleep apnea, go over some of the, available categories of treatment that we have, talk about the pros and cons for individual modalities, then go over some of the new and promising interventions that we have, and go over evidence-based recommendations and the future of OSA treatment. Well, hopefully we'll have a few minutes to talk about that. So I'm going to start with a case. So we have a 48-year-old man with difficult to control hypertension on 3 different blood pressure medications. He has atrial fibrillation, recently failed an ablation procedure. He's diabetic. His hemoglobin A1C is 9, so he's not very well controlled. Erectile dysfunction, memory impairment. We see him in the office with his wife. His wife says that he has episodes of gasping in the middle of the night, but he doesn't really snore that much. He says that he's not sleepy, but he's just tired. Every afternoon he's very tired. On exam, he is obese. He has a large neck, and when we look at his oropharynx, we see a crowded airway, large tongue, low soft palate. I think that's what we would call a Friedman class 4, basically, when we look at his classification. So the question is, what is the most important next step to consider, in this man's evaluation? And this is just a quick, warm-up question. Obviously, I think the answer is obvious. Do we rule out thyroid disease? Do we evaluate for secondary cause or hypertension? Or do we really have to go after obstructive sleep apnea if we think that that's going on, evaluate for renal disease, or adjust his diet and exercise? So as I mentioned, it's, there are many red flags here. The history of resistant hypertension on 3 different blood pressure medications, more than 60% of the time, this is someone who has untreated, undiagnosed obstructive sleep apnea. The multiple attempts at cardioversion and ablation of AFib, erectile dysfunction, poorly controlled diabetes. Witness apnea is one of the most specific symptoms of OSA. The high BMI, large neck, crowded oropharynx, and without diagnosing and controlling OSA here, we won't be able to really optimally control all the other problems that he has. We can continue to add more blood pressure medications, but without treating OSA, it's going to be difficult. So very briefly, so OSA by definition, it's obstruction of the upper airway during sleep, right? So we define the upper airway as the nasopharynx, oropharynx, and hypopharynx. And narrowing or obstruction in any of these stations, basically, when combined with loss of muscle tone during sleep, as we can see here on this dynamic CT scan of the neck, you can see obstruction, recurrent obstruction of the upper airway during inspiration. And this obstruction can be of variable degrees. So some people might have just very little airflow limitation that just cause snoring sounds. Some will develop airway resistance and multiple awakenings, what we call upper airway resistance syndrome. Airflow can be more limited, maybe 30% reduction in airflow, what we would call hypopnea, all the way to more, 90% or more cessation of flow, what we would call obstructive apnea, all the way to daytime as hypoxia and hypercapnia, and what we would call, basically hypoventilation syndrome. The way we define severity now is by looking at the AHI. As you guys know, the total number of apneas and hypopneas divided by the total hours of sleep. And if that number is less than 5, it's considered clinically not significant. 5 to 15 is mild, 15 to 30 is moderate. More than 30 is considered severe. But this concept of using just the AHI as the only index for severity is being challenged recently. We all know that how bad hypoxia is a factor. How deep do they desaturate? How long do they stay below 8%? The concept of sleepy versus non-sleepy obstructive sleep apnea patients, we know that the sleepy patients have more cardiovascular risk. And then this issue of circadian or nocturnal blood pressure dipping. Normally, blood pressure would dip by 10% or so at nighttime when you're asleep. Patients who are non-dippers have high risk of cardiometabolic comorbidities. So I think we are going to be seeing maybe a combination of these factors here to come up with a better measure for severity of disease in the future, in the near future. And obstructive sleep apnea, we really look at it as a multi-system disorder. So we know that these patients can have cardiovascular comorbidities like, again, atrial fibrillation, heart failure, risk of stroke is increased, poorly controlled blood pressure, metabolic derangement, like increased insulin resistance specifically. We see cognitive impairment, we see sexual dysfunction, low testosterone levels, and we see excessive daytime sleepiness and increased risk for motor vehicle accidents. So we're not just treating the AHI. And how common is this problem? Well, in the United States, we know that in men it's about 10 to 17% depending on age, and 3 to 9% in women have moderate to severe obstructive sleep apnea. But if you look at the general population, all adults between 30 and 70 years of age, we see that 1 in 3 men and 1 in 5 women, more or less, would have an AHI more than 5. So very common. And I looked at prevalence in Egypt. I looked for some studies, and you guys know this probably more than I do. But I found this study from Asyut that showed a 14% prevalence in Upper Egypt. And there was a small study that looked at the railroad drivers and found a prevalence of 4.2%. And the study that was in a high-risk patient population, liver cirrhosis patients, that showed a prevalence of 56%. So there's a broad range of prevalence. What we really know and hear from Europe and the United States, that 85% of patients remain undiagnosed, actually. So we just diagnosed the tip of the iceberg. And when it comes to sleep testing, of course, that deserves its own lecture. We know that in-lab polysomnography is the gold standard for diagnosis. But if our primary concern is obstructive sleep apnea, then home sleep testing is really all we need. It's a simple kit. We test breathing, we test respiratory effort, oxygen saturation, and we get the diagnosis. And I can tell you this is the most commonly used method for diagnosis in the United States. WatchPad is one of the newer technologies. I don't know if you have it in Egypt now or not, but it's basically based on monitoring peripheral arterial tone, which basically represents sympathetic tone. And so we use this as a surrogate with arousals that are sympathetic tone changes. We combine that with oxygen saturation, actigraphy, and we can make a diagnosis for obstructive sleep apnea. So it is, FDA approved, and it's being used here in the United States. Mass General Hospital, for example, uses it exclusively. So our patient had a sleep study, has an in-lab study, and as you know, it's a very comprehensive test. This is one of the softwares we use here, and as you can see, we see eye movements, EEG, chin, EKG, leg movements, snoring channel, but this interval is a 30-second interval between each of these lines here. So you can very easily see an episode of no flow despite effort to breathe, followed by an arousal on the EEG, airway opening, and then we see the oxygen desaturation follow through. And we can see that this repeats every 30 seconds, so this is someone with very severe disease. So that brings us to treatment, which is what I want to focus on with the next several minutes here. So the question is, do we treat everyone who has a positive sleep study? And the answer is no. So we offer treatment for patients with moderate to severe OSA. We think that that would improve their outcome. Patients with mild OSA, those with AHI just between 5 and 15, we only treat them if they have evidence of cardiovascular disease, neurocognitive dysfunction, or excessive daytime sleepiness and fatigue. So if someone gets a sleep study because their bed partner is complaining about snoring, for example, and they have an AHI of 7 or 8, there's really no evidence that treating someone like that who's asymptomatic would improve their outcome. And when it comes to treatment options, the three major categories of treatment that we always talk about are surgical interventions if there is a very clear site of obstruction. I'll talk about that more in a bit. Oral appliances, which would just move the lower mandible forward and get the tongue out of the way and open up the airway, and of course positive airway pressure therapies. In addition, we just make general recommendations for every patient, sleep nasal allergies, weight loss, avoiding supine sleep, and avoiding alcohol and sedatives. So that's all we had until the last 10 years, 15 years. There's been a plethora of treatment options around. Some of them have fell out of favor already. So continuous negative external pressure, for example, is a cuff that's applied to the outside of the neck, applies negative pressure on the outside, and it pulls the soft tissue and the base of the lung forward to open up the airway. That we don't use that anymore here. We still use it on the inpatient side for endoscopy procedures, for example, combined with conscious sedation. The Wink system, it's a device that creates negative suction within the airway, pulls on the tongue and open up the airway. Again, fell out of favor. In Beth Israel Deaconess here in Boston continues to use it, but not many other places. Provent, which is basically, it's a one-way resistor valve, that's attached with adhesive to the front of the nostrils like that. And it basically creates positive pressure in the airway. It creates end expiratory pressure with breathing, and it can, treat mild obstructive sleep apnea. But I just recently learned that they stopped manufacturing it, so we're not going to see that much anymore. And then there are other options that are still in use, and some of them are on the rise, actually. The tongue stabilizing devices have been around for a while. It's basically like a suction cup. The patient just puts their tongue in, and it will just keep the tongue pulled throughout the night away from the airway. Some patients like to use this when they travel, for example, away from their CPAP machines. Positional therapy plays a big role, either as a supplement treatment or as the only treatment. We're going to talk about that a little more in a minute. And then there's some new technologies like this, daytime, electric neuromuscular training of the tongue muscles. We'll talk about a little bit more. Of course, hypoglossal nerve stimulation plays a big role now, and it's solidified its role in the algorithm for treatment of OSA, and we'll talk about that. And then one of the most exciting areas is really the pharmacologic therapy. Every patient who walks through the door asks me, so there is no pill I can take to fix my OSA, and I don't have to use my CPAP machine. So we'll talk about that in a minute. But, just going back to where it all started, really, so positive airway pressure therapy. The reason why it has been the go-to treatment for such a long time is that from day one, once we pressurize the airway, we're pressurizing the nasopharynx, the oropharynx, the hypopharynx. It doesn't matter where the obstruction is. You don't need to know where the obstruction is. Put the mask on, positive pressure, you open up the airway, whether they have a large neck, obese, non-obese, it works. And there are different ways to do this. Of course, the continuous positive airway pressure, we set the pressure at 8, 9, 10 based on a titration study to keep that airway open. Or we can use auto-titrating PAP, which basically we set a range of pressure between 5 and 20, for example, and the machine can sense when there is airflow resistance, and it will go up or down based on the patient needs. So, for example, they go between RAM and non-RAM, or they change positions. It can titrate up and down. I can tell you this is the most commonly used machine for OSA here in the United States now. We just started without sending patients for a titration for the most part. BiPAP still plays a role. Basically, as you know, it's we set an IPAP and EPAP. It's really useful for patients who require higher pressure. So if someone needs a CPAP of 18 and it's very uncomfortable, when we switch them to BiPAP, it's a little bit more comfortable, taking higher pressure in, lower pressure out, more physiologic. Very useful for patients who have severe desaturations, patients who have comorbidities like COPD, obesity, hypoventilation, etc. So adaptive thermoventilation, I'm not going to spend too much time on this. It's not a treatment for CPAP. It's not a treatment for OSA. So we only use ASV for patients who develop central apneas while they're on positive pressure titration. And we think that this is because of they're too sensitive to CO2 changes during titration. They have a high loop gain, for example, and that, their ventilation becomes unstable. So in that patient population, we would use ASV because it has the EPAP to fix the obstruction, but it also has the variable inspiratory pressure to stabilize ventilation for these patients. We just have to avoid it in patients with heart failure and a low ejection fraction based on the SERVE-HF trial that showed worse outcomes in that patient population. So CPAP, like I said, has been around for a long time, since the early 1990s, but the devices have become really much easier to use, much more sophisticated, quieter, smaller. We see travel CPAPs that, basically is the size of an iPhone. So the technology has changed a lot. And as far as efficacy, it has been around the longest. So we have a lot of evidence and a lot of research that has been done on CPAP and comorbidities. This study, for example, is a systemic review from the Cochrane database that showed CPAP in general, was more effective than control for treating daytime sleepiness. And when we look at studies that had a crossover design, that effect was maintained. So it favors CPAP versus control, yes. So we know that CPAP definitely treats excessive daytime sleepiness. In this study was a randomized controlled trial of patients with moderate to severe OSA who were treated with effective CPAP here in the closed bars. And we can see that effective CPAP lowered the mean arterial pressure, systolic and diastolic pressures by 10 millimeters mercury compared to subtherapeutic or sham CPAP here in the open bars. Then the concept of non-dippers, again, this Spanish study looked at 12 weeks of CPAP use in patients who had this dipper versus non-dipper circadian blood pressure pattern, and found that there was a significant improvement in blood pressure in patients who were non-dippers. So that's maybe a subgroup of patient population that we should focus on. And the reduction was in 24-hour ambulatory blood pressure and in nocturnal blood pressure. In this study here, they randomized patients to CPAP use for 3 months in patients with idiopathic and non-idiopathic cardiomyopathies. So idiopathic and ischemic cardiomyopathies. Use of CPAP for 3 months was associated with significant reduction in ejection fraction in the CPAP group versus the control group. In if we look at the recurrence of atrial fibrillation after a catheter ablation procedure, like the pulmonary vein isolation here, for example, we find that patients with OSA who were using CPAP had a 50% reduction in recurrence of their AFib. Their risk basically has become equal to patients who did not have OSA. And in this meta-analysis, they looked at the incidence of stroke, incidence of cardiac disease, and incidence of cardiovascular events in general in patients with OSA who were using CPAP, and found that the use of CPAP was associated with 70% risk reduction of incidence of stroke and a 45% risk reduction in cardiac events. And the last study I'm going to talk about here is this. It was a large epidemiologic study that looked at overall mortality in patients with OSA who were using CPAP. So we see that patients with moderate to severe OSA who were using CPAP had a low mortality that was similar to patients who did not have OSA compared to patients who had moderate or severe OSA that was not treated. So, but the data was not all great for CPAP. There is other group of research studies that came out that's challenging the use of CPAP and the efficacy of it. So, for example, the SAFE trial, which you might have seen here, that came out, I think it was 2016. It was a large randomized control trial, almost 3,000 patients with moderate to severe OSA and coronary and cerebrovascular disease. So they were looking at secondary prevention here. They randomized them to CPAP plus usual care versus usual care alone. They monitored them for almost 4 years, and they found that there was no difference between CPAP and the usual care when it comes to the primary composite endpoint of death from cardiovascular causes, MI, stroke, or hospitalization because of cardiovascular disease. And the REGATS trial that was done around the very same time showed similar findings, but they did find that outcomes were better in CPAP compliant patients. So there has been many limitations with randomized controlled trials for OSA in general. In this specific trial, these studies generally tend to exclude patients with excessive daytime sleepiness and exclude patients with severe desaturation. It is considered unethical to randomize them to the control arm of the study. In the SAFE trial, they included patients with established cardiovascular and cerebrovascular disease. So we did not test basically primary prevention. And the bigger problem was adherence. In this study, it was only 3.3 hours per night. And we see this across the board in some of these randomized controlled trials. That's the SAFE trial group went back and looked at the group that used their CPAP machine for more than 4 hours and found that there was actually improved cardiovascular outcome in that group. So the problem with CPAP is really adherence. I mean, we know it's effective. The problem, how do you get the patients to use it and be able to use it all night long, not just 2-3 hours a night? We know that adherence is better when these patients are managed in sleep clinics, specialized sleep centers, board-certified sleep physicians, for example, here in the United States. So what we do is we bring the patient back to the clinic and we go over all the issues that they might be having. Is it like nasal sinus congestion and allergies? Is it, claustrophobia? Is it skin irritation? Is it the wrong mask? Is it insomnia or some other sleep problem that they have? Is it a socioeconomic issue? Is it a patient education issue? So we go over all of these issues. We go over a lot of different masks. Nowadays, there's really no end to the number of masks we can try, and they're of different comfort levels, of course, but most patients are thinking of this full face mask and they don't want to use it. If someone is a mouth breather, we can use a shin strap, for example, with one of these nasal interfaces. We download compliance data of their machines, which gives us a lot of very useful information. If you look here, these are the number of hours they use every night. For example, we can see that they skipped using it for a few nights. They didn't use it as much like that night. We look at air leak data, and for example, this patient has a ton of air leak. So, we can very quickly just go back, okay, we need to fix the leak. We need to maybe adjust the pressures if needed. And we can look at residual apnea-hypopnea index too and make sure that they're well controlled and make adjustments as needed. And with all of that, we can really improve their compliance. So the American Academy of Sleep Medicine published a meta-analysis of 184 studies and made the following conclusions. So PAP therapy compared to no treatment results in clinically significant reduction in disease severity, sleepiness, blood pressure, motor vehicle accidents, and improved sleep-related quality of life. So those are the things I think that we can agree on CPAP does. Ambulatory CPAP initiation, just in the outpatient setting, is equivalent to in-lab titration. Auto PAP is equivalent to CPAP as far as outcomes, and as I mentioned, we use auto CPAP, most commonly here in the U.S. And patient education and telemonitoring and reviewing their compliance, all of that really help the patient, continue to use the machine long term. So moving on from CPAP now to mandibular advancement devices, and these devices just simply work by moving the lower jaw, the mandible forward, pulling the base of the tongue out of the airway during the night. So the patient put this in before they go to sleep, and they take it off when they wake up in the morning. There are multiple appliances out on the market. They all work with different systems. Basically, we send these patients to a dental sleep medicine provider, someone who specializes really in dental sleep medicine. They use a device like this to, advance their lower jaw gradually. So they do maybe like 1 millimeter at a time, really to stretch the muscles and the ligaments and to prevent any tension on the temporomandibular joints. The goal is to get a 50 to 75% protrusion from their habitual bite, going from here to here. This table here shows the different studies that were done to look at efficacy of these appliances, and they define the efficacy as a 50% drop in the AHI. And as you can see across the board, it's about 2/3 of patients, have success with these devices, more or less. But it really all depends on picking the right candidate. So the best candidate for this therapy, younger patients do better, women do better than men, patients who are non-obese do better, small neck circumference, patients who have retrognathia, like I show you in these images, smaller mandible, like an overbite, short, soft palate, and patients who have mild to moderate disease. We don't know really if it's efficacious in patients with severe disease. And then patients who have positional sleep apnea, so patients who have predominant supine sleep, because if their disease is predominantly in the supine position, it indicates that it's the anterior-posterior dimension is the problem, and that's the dimension that the oral appliance would fix. So if you find a patient like this, oral appliance can be a great option. Nowadays, we can monitor compliance. We don't just ask the patient, are you using it or not? There are new technologies that are thermal sensors actually that can be added in the oral appliance, and it can tell us how long they've used the device. And what's really exciting are these new biosensors that's going to give us a lot of physiologic data. This is new. This is not in development. We actually have it in our center, but studies are ongoing, of course, to show its efficacy. But it can monitor things like oxygen saturation, plethysmography, peripheral plethysmography, exactly like a pulse oximeter on the finger, but even more central. Heart rate variability and blood pressure changes. So you can call it basically a smart oral appliance. So a lot of exciting developments here in that field. So moving on to surgical interventions, really the key with surgeries, and it has been the case for many years now, is to pick the right patient, the right surgery for the right patient, basically. If you find a patient that has one station that's causing the problem, for example, a very long soft palate with a large uvula, then a UPPP would fix the problem. Or like a very narrowed hypopharynx, for example, then a hyoid bone suspension would fix the problem. But the problem is if you do this, but they have a hypopharynx that's obstructed, or if they have a nasopharynx that's a problem, or they have a very large neck, it's not going to work. The surgery that really is most effective is the maxillomandibular advancement, which very effective in fixing the disease, but it's basically a reconstruction of the maxilla and the jaw, breaking the bones, pulling it forward. So the patient is, they have their mouth wired shut for like 3 weeks. So, but every now and then we have younger patients. I was just seeing a patient yesterday that wants to go for this procedure, 25-year-old with severe OSA. They don't want to be using CPAP, for example, for the rest of their life. But the surgery that really carries the most potential is, and the most promise, I think, is this hypoglossal nerve stimulation. Basically, it's a generator that gets implanted in the subcutaneous tissue here, like a pacemaker, under the clavicle. There is a sensing wire that goes and it's implanted between the ribs. There's a stimulation wire that's tunneled, and it goes with a cuff around the hypoglossal nerve. And basically, once this hole heals, the patient can use a remote device to turn this on. And with every breath they take in, the device will actually stimulate the tongue to move forward during inspiration and open the airway. The key thing is to find the right spot to put the stimulation cuff, basically very distant in the hypoglossal nerve, to get to the genioglossus muscle and geniohyoid muscle to move the tongue forward. If you do it proximally, you might get the opposite effect. And this is just to show you how it works with laryngoscopy. So this is with no stimulation. So this is the base of the tongue. This is anterior here. This is anterior. So this notch is anterior. And you can see, I'll show you. It's just barely opening. This is the epiglottis here. It's barely opening. Sorry, can you hear me? This is with stimulation, and you can see that with inspiration, how much the tongue can move forward, how much the airway is open. That's the same patient. So big difference. With inspiration, the tongue is moved forward and the airway opens up. So who is the best candidate for this procedure? It's indicated for adults, basically 18 years and older, non-obese, so BMI less than 32, moderate to severe OSA, so AHI between 15 and 65. It's still recommended to try CPAP first. So patients who cannot tolerate CPAP or who fail CPAP would be good candidates for this. And then we get a DISE procedure, basically drug-induced sleep endoscopy. So we give these patients a little bit of conscious sedation just to make them sleepy and look at their airway. What we want to see is during inspiration, we see this anterior-posterior collapse and not concentric collapse, because this is the only dimension, again, that the hypoglossal nerve stimulation would help. The tongue moving forward and opening this dimension. If the lateral walls are collapsing, that's not a good candidate for this device. And the landmark trial that got this device approved actually in the United States back in 2014 was the STAR trial, where a moderate to severe obstructive sleep apnea patients had a 70% reduction in their median AHI. It went from 30 or so down to 7. And by the end of a 12 months period, they had pre-planned a randomized therapy withdrawal trial. And the group that got therapy withdrawal got recurrence of their disease compared to the therapy maintenance group, suggesting that improvement was directly related to hypoglossal nerve stimulation. And that same group of patients was followed for 5 years, and we can see that the improvement in AHI persisted. The improvement in daytime sleepiness also persisted. Patients with the device can connect to an app on their phone. They can monitor their treatment. There's a cloud-based system that we can see in the clinic and see, how often they're using it, how strong their stimulation is, and we can make adjustments as needed with the patient. So it has been very successful. Now, moving on to this idea of basically electric neuromuscular training of the tongue. And this is a relatively new technology. It's using a device that has a mouthpiece that goes, around the tongue. It has a pulse generator, and there's an app that connects to it. And Basically, patients turn this on and use it for 10 minutes, 20 minutes a day, and it exercises the tongue muscles basically. And so, in this study of patients with mild obstructive sleep apnea who used this device for 20 minutes every day for 6 weeks, they showed significant improvement in AHI and significant improvement in daytime sleepiness. So this device actually is FDA approved now in the United States for use in patients with mild obstructive sleep apnea only. Another thing that's been around for a while is positional therapy. It can be a supplemental therapy, but it can also be the only treatment option that you provide for someone who has predominantly supine OSA. For example, someone whose AHI is 30 when they're sleeping on their back and they go to their side and their AHI goes down to 5. This might be the only treatment they need. And there are many different forms. If you go online, there's so many different options. The pill here is one of the more comfortable options that I see patients using. This is a device that, vibrates every time the patient goes on their back. Not very many patients, like to use that, but there are many options out there, and patients can make up their own, basically, systems. Finally, pharmacologic therapies. So that has been an area of, heavy investigations over the last, decade or more. But as we understand the endotypes of disease, basically the root cause analysis of the problem, we are able to identify 4 categories or 4 areas that we can focus on. If it's a problem with upper airway patency, weight, for example, nasal sinus congestion, then using simple things as nasal decongestants, but the more exciting work is done with weight loss medications. We know things like semaglutide, Ozempic, for example, has been very popular. They're very effective. So many studies are ongoing now with the use of these medications for treatment of OSA. If the problem is, pharyngeal dilator function that's impaired, for example, we can use things like a serotonergic, noradrenergic, or a calcium channel blocker medications that would improve upper airway recruitability. If it's a problem of high loop gain, unstable ventilation, basically unstable ventilatory control of respiration, we can use carbonic anhydrase inhibitors to stabilize the system. And then if it's a problem of low respiratory arousal threshold, someone who wakes up very easily, their sleep is very unstable, and that would cause their upper airway patency to be unstable too. So giving them medications to raise their arousal threshold can allow time to recruit, dilator muscles and overcome that upper airway obstruction. So more to come on this. Every single drug I listed here, there are many research studies ongoing testing its use in patients with OSA at different phases. So, more to come from this exciting area. I just brought one example. It's done in our center, actually, was the use of a combination of atomoxetine and oxybutynin to reduce OSA severity. It was only 20 patients. It was randomized control, but we find that the combination therapy significantly dropped AHI. But more importantly, it did that with improvement in genioglossus muscle. So improving the function of the genioglossus muscle, helping it keep that airway open overnight. So just like almost a summary slide here. So the European Respiratory Society published their guideline on non-CPAP therapies for obstructive sleep apnea, and they made conditional recommendations for bariatric surgery for obese OSA patients who fail conventional weight reduction. CPAP is still recommended over mandibular advancement devices for OSA in general. Hypoglossal nerve stimulation should not be used as a first-line therapy for OSA. So again, try CPAP. If they fail, then that might be a good option for them. Maxillomandibular advancement surgery is an alternative to CPAP in the right, again, patient. And positional therapy for supine predominant mild to moderate OSA is a viable alternative to CPAP or mandibular advancement device. And, pharmacologic therapy in general has a potential for being successful in treatment of OSA, but it should still be used within randomized controlled trials. They're not ready for prime time yet. So finally, how do I do it? I get a patient with obstructive sleep apnea. If they have moderate to severe OSA, I think the overwhelming evidence is still to try CPAP first and work with them to make it successful. But if we can't, if they are not able to tolerate it, then we can consider hypoglossal nerve stimulation or mandibular advancement device, depending on their anatomy, like I said, their phenotype. If they have mild disease to begin with, then I just go over the whole gamut, the whole menu with them, and depending on their phenotype and endotype, like we discussed, we can take a treatment option. But really, the future of treatment of OSA is really this personalized management, approach. So as we continue to learn more about the different phenotypes and endotypes of obstructive sleep apnea, the root cause of their disease, basically, we're going to be able to pick, targeted therapies. And I think, we are developing the tools to do that. And, it might be that for someone that, has OSA, they might get an oral appliance with a medicine to lower their arousal threshold, or to increase their arousal threshold, for example. Or someone might get hypoglossal nerve stimulation and a medication. Someone might need bariatric surgery and maybe supine, like positional therapy, and that's all they need. So we were going to see more of that, over the next few years. Definitely, it's not, CPAP is not, one treatment, fits all. So hopefully, I would leave you with some take-home points here. So OSA is common, yet remains largely underdiagnosed in the general population. Untreated OSA is associated with multiple negative cardiovascular, neurocognitive, and metabolic consequences, in addition to daytime functional impairment. PAP therapy remains the mainstay of treatment for moderate to severe OSA. Efficacy is the biggest advantage of PAP therapy, but the problem is adherence. And alternative modalities are indicated in specific situations, as we discussed, but really personalized approach to each individual patient should be the standard of care over the next few years. And that's all I have. And hopefully it was useful for everyone. Thank you for having me again, and thank you for inviting me. I'm happy to answer any questions.
Thank you, Professor Khaled, for this comprehensive presentation that sum up all the treatment and the updates in management of obstructive sleep apnea. And my first question will be, in patients with mild obstructive sleep apnea, knowing the current limitations for the apnea-hypopnea index, if the patient is asymptomatic and does not have any comorbidity, do you consider treating such patients or just following them up?
There's really, no evidence that treating such a patient will, really improve their outcome at all. It has been a very controversial issue, over the past few years. And, there was some suggestion that it might decrease the risk for development over the long run, but there's really no great evidence to support that. So I basically give them the option. I ask them, so you're not sleepy at all? There's no symptom that we can go by, but if they say no, yes, I just follow them up. If they're overweight, they can lose some weight. They have nasal sinus congestion and allergies, we can treat that. So just, some supportive things like that. If snoring is a problem and they want to take care of the snoring, then, we can use some of these treatments that just focus on snoring and not OSA.
Thank you. Question? We have another question, please.
Okay.
Thank you so much, Professor Khaled, for your kind and conclusive topic. Yeah. My question is regards to the hypoglossal nerve stimulation. We now have two pathways or two methods for this new line of treatment, the non-invasive and the invasive. First, sorry for that.
No problem.
We need to make proper patient selection in order to choose which method of treatment, because the non-invasive is not still documented for the patients with severe obstructive sleep apnea. Still, the results are not satisfactory in this group of patients. But regards to the mild and moderate obstructive sleep apnea patients, comparing the non-invasive to the invasive, do you think that the invasive is more superior to the non-invasive, and why? And what are the most common complications with the invasive method of treatment?
Yeah, so when you say non-invasive, you talk about the daytime electric neuromuscular training for the tongue?
Yes.
Is that what you mean? Yes. Yeah, so yeah, that's really like very early in its usage, and we don't have a ton of experience with it. So it's only indicated for patients with mild disease. Hypoglossal nerve stimulation now has been around since 2014, so we have a lot more experience with it. Safety has been, improved significantly. So I would say, again, they treat, so one of them only treats mild disease, and the invasive one treats moderate to severe disease. If you get the right patient candidate, I think that's the key thing, so someone who is not obese, someone who you do the DICE procedure, and you find that they have this anterior-posterior collapse. And also I would say, the personality of the patient matters. And we had patients who, like they're very anxious or very OCD, and they had trouble actually tolerating the nerve stimulation and acclimating and allowing us to titrate, because you have to titrate the stimulation. We start with very low levels for the patient just to get used to that tongue movement, but we have to titrate it up. We bring them back to the sleep lab and titrate the device up. So the patient has to be, educated enough and willing to work with you on that. As far as complications, they're really, really minimal. The only thing, I think there is a registry, it's called the ADHERE registry, that has been including every patient who got the device, and now I think it has thousands of patients now. I think they implanted like 40,000 devices, at least in the United States. The main complaint may be, like in the majority of patients, is tongue discomfort. That goes away with time. That's it. So, we were worried about like the wires causing complications or infections or not. We haven't seen any of that. It's really just the tongue discomfort. The generator itself, used to be, so you cannot get any CAT scans or MRIs. But the device now, the second generation devices can be used even with MRIs. So yeah, the technology has developed significantly over time. It's become very safe.
All right. Thank you so much. Thank you.
No problem.
Thank you, Professor Khaled. We really enjoyed your presentation, and I'm very pleased that the first time you present for Egypt was in our Congress. Thank you very much for the presentation, and hope you have a nice day.
Thank you. شكرا. Thank you for the invitation. وأنا سعيد جدا إن أنا كنت معاكم النهارده، وإن شاء الله نشتغل مع بعض in the future as well. Thank you.
Again, we appreciate very much your contribution, and we are looking forward to see you here in Cairo to be face-to-face presentation, inshallah. Thank you very much.
Thank you.
And now I have the honor to present Professor Safwan Badr, who will speak about sleep apnea. It's more than what you think.
Good morning. Thank you for inviting me to speak at your esteemed conference. It is truly a pleasure and an honor to speak to you. Today we are going to talk about sleep disorder breathing, otherwise known as sleep apnea. And the title is Sleep Disorder Breathing, It is More Than You Think. We always like to start with disclosures, and I have no conflict of interest to disclose. The objectives of this presentation is to talk about sleep deficiency first. What is sleep deficiency and what are its implications? And then describe the clinical conditions associated with sleep apnea, then outline a diagnostic and a management approach. Why do we sleep? Well, this has always been a mystery, and there has been debate in the field. Obviously, poets would say their sleep is not necessary. It says, فَمَا طَالَ النَّوْمُ عُمْرًا. However, that's not what science says. Science says sleep is essential to life and function. One of the more recent theories that have become very popular in the past 10 years is that sleep itself opens up spaces between the glia, which is called the lymphatic system. So usually there are no lymphatics in the brain, and as you can see here, it's a convective flow that allows the metabolic waste to actually drain into the vein. And this space is usually closed in wakefulness and open during sleep. So the analogy that has been used is that sleep is like the garbage truck of the brain. In this slide, this is a cerebrospinal fluid influx in a murine model. And what you can see on the left side is red, which is a sleeping mouse, and on the right side, the green is an awake mouse. And what you can see is that the space is larger. There is a more influx of cerebrospinal fluid in the brain of a sleeping versus an awake mouse. So the idea here is that sleep clears the brain of accumulating metabolic waste, which is typically beta amyloid that's excreted into the extracellular space and has a local toxicity. So sleep deprivation produces accumulation of amyloid, and chronic sleep restriction would promote amyloid plaque formation, which is characteristic of Alzheimer's disease. So sleep deficiency is either an insufficient sleep, short sleep, either because of insomnia or sleep curtailment, could be poor sleep quality, such as sleep disorder breathing, sleep apnea, or periodic movements during sleep, could be circadian misalignment, shift work, jet lag, circadian rhythm disorder, or sleep disorders, such as narcolepsy. Now, our current culture values wakefulness, staying up late, burning the midnight oil. And this actually goes, in the Western culture, dates back to Thomas Edison, who said that sleep curtailment, sleep is a criminal waste of time. So for him, sleep curtailment was a virtue. And to us, this was the beginning of the dark ages of sleep health. And now we know that sleep curtailment is not a virtue. It's not a value. It actually makes you grumpy, accident-prone, and obese. Why is that? Because short sleep duration is actually associated with reduced leptin and elevated ghrelin. Again, leptin is the satiety hormone. When leptin is high, we feel full. Ghrelin is the hunger hormone. When ghrelin is high, we actually feel hungry. And in this one, on the top one is leptin, and as you see, the leptin level is higher as we sleep longer, and this is the reverse is true for ghrelin. Ghrelin levels decrease when we sleep longer. So typically speaking, insufficient sleep, short sleep, is associated with more food intake, with more hunger, and actually poorer food choices. Now, short sleep duration is also associated with higher BMI. And as you can see here, between 7 and 8 is the lowest BMI. Now, one of the mysteries in the field, which we always get, why is it a U shape? Why do we see a higher weight for somebody who sleeps longer? Well, most scientists believe that this is actually reverse causality. So people who are more obese tend to have more medical problems, more comorbid conditions. They tend to spend more time in it. So it's a reverse causality. This one we can intervene, this one is reverse causality. And the same thing actually happens in relationship to mortality. And again, it's a U-shaped relationship. Somewhere around 7 to 8 has the best, highest mortality. Now, sleepiness is responsible for many accidents, including industrial accidents as well as motor vehicle accidents. So, the most famous of those is the Space Shuttle Challenger. And in every country you will find examples of these. And the Challenger in particular actually was studied, and the Presidential Commission on the Accident Report addressed sleep deprivation and said that the willingness of NASA employees to work excessive hours while admirable raises serious questions which jeopardizes job performance. So given the value of sleep, there is a desire to know what is an optimal sleep duration. So the American Academy of Sleep Medicine, the Sleep Research Society, and the CDC, they partnered in this project, and I was fortunate enough to be part of this panel that looked at what is the optimal sleep duration. So this started by a review of the literature of several hundred articles, narrowing them down to several categories, and then do multiple levels and layers of voting to rank style. But this is the final summary of this. And on what you can see, anything on the left here are the different categories where it could be affected by sleep. Anything that red, meaning it's bad for you, and there's agreement. Anything in green is good, and there's agreement. And the other things are somewhere in between. So just one broad look at this slide, and you'll see that below 6 hours was bad in most categories. However, metabolic health and general health required more sleep. So in summary, we can't really say that one area is actually it needs more sleep than others, but there are two: metabolic health and general health. So the summary of the panel was adults should sleep 7 or more hours per night on a regular basis to promote optimal health. This was the summary of several days of discussion and months of review of literature as a summary. Other professional societies have done similar things, and they reach similar conclusions. Now, one question is, what about more than 9 hours? The committee did not take a position on it and said this may be appropriate for some individuals, but if somebody has concern about it, they should really seek healthcare advice on this one from their providers. So now when we talk about sleep, we talk about wellness, we talk about exercise, we talk about nutrition, and now we add sleep to it as one of the components. So now I'm going to switch to sleep disorder breathing. And one of the things we know that while sleep is a restorative part and rest for most organ systems, it is actually a challenge for the respiratory system. And there is a continuum of collapsibility. Why is it a challenge? Upper airway narrows, even in healthy individuals. Those who snore, it narrows more, and it starts vibrating. And if it narrows even more, then it obstructs. Now, the typical symptoms you all know: snoring, excessive daytime sleepiness, which we can measure using multiple instruments. If there is a spouse or a bed partner, we hear about witness apnea, they witness them stop breathing, multiple arousals, morning headache, reflux, and I would add nocturia. These are symptoms that are indirect but actually are very significant. Headache, nocturia, and reflux. And on a polysomnogram, this is what a typical sleep study will look like. This is one epoch. The top here, eye, and this is EEG and EOG, this is chin EMG. We have leg movement, we have flow, sum, which is sum of the two bands, the abdomen and the ribcage, and then the saturation. The arrow is showing you cessation, full cessation of breathing, which is, by definition, is what an apnea is. However, this is happening in conjunction with persistent effort. That effort is persisting, which makes it an obstructive apnea. This is followed by, you see this perturbation here, that's an arousal. And over a few seconds longer, you see a decrease in saturation. And that delay is because we need time for the signal to actually reach the carotid, to reach the periphery, to be able to be picked up. And in a typical idealized scenario, this is what's called the hypnogram. The first half is before we apply nasal CPAP, and what you can see is all the episodic desaturation up and down. And the band here, OA, is a whole bunch of obstructive apnea. When we added CPAP, continuous positive airway pressure, gradually you'll see that there was an elevation in saturation and a decrease in the magnitude of the fluctuation. This tells us this is an effective CPAP level. So how prevalent is the disease? And that actually, the numbers I'm going to give you are numbers relevant to the United States. I do not know, I have no data on what the prevalence is in other countries. And the reason why this distinction is important is obesity rates are not the same, and this may be one of the drivers. Obviously, upper airway anatomy, especially skeletal structure, is also a variable. There are parts in Asia, for example, where individuals who are not obese will develop more sleep apnea than other parts of the world because of the shape of the mandible and the shape of the face. So this is the first study that was based on the community participation. This is called the Wisconsin Sleep Cohort Study, and I was also fortunate to be part of this group that performed this epidemiologic study. And this one looked at employed individuals between the ages of 30 to 60 who lived in Wisconsin or the county surrounding the city of Madison, Wisconsin. For the men, 24% of the men met the minimum diagnostic criterion of more than 5 events per hour sleep. Snoring men, it was 33%. Non-snoring men, it was about 15 or 17%. In women, that number was 9%. And again, for total, and for snoring women was somewhere around 20%. So that gives us the prevalence of the disease. However, I'm going to move it a step further to another group study, which is from Hershey, Pennsylvania, which looked at a variety of measures, but this is the one that more reflects a syndrome of sleep apnea plus symptoms. And you can see that the numbers are somewhere 2 to 4%. By the way, the Wisconsin Sleep Cohort study, when they added sleepiness to the measures, so 5 events plus sleepiness, it was 2% in women, 4% in men. So 6 years later, these numbers were similar in Hershey, Pennsylvania. But then, what's the impact of obesity on the prevalence of the disease? This is the obesity map in the United States in 1993. The dark blue is reflecting 15 to 19% obesity, defined as BMI over 30. Now, this is 1999, and the yellow is obesity rate. This is 2010, and what you can see right now, the red is more than 25%, the dark gray is more than 30%. And this is the map in 2018. What you can see is again the same issue. More than 35%. In most of the country now is above 25%. So that's a change over a 30-year time span. Well, what impact does this have on the prevalence of the disease? Well, this is again back to the Wisconsin sleep cohort study. They looked at the numbers in 1988 to 94, and this was the prevalence. And then they looked at the numbers again in 2007 to 2008. So in men, the prevalence went up from 26% to 34%. And if you think of a syndrome of sleep disorder breathing plus sleepiness, it went from 10.8 to 14.3. And in women, it went from 3.8 to 5%. So clearly, in any society, the higher the obesity rates, the higher the prevalence of the disease. And I think it would be very important to do this analysis in different countries, to conduct epidemiologic studies in different parts of the world, including Arab countries. Now, other conditions that may affect is reflux. And one of the things we see, patients with sleep apnea report reflux symptoms. And the reason for it, you're generating a negative pressure against an occluded airway. And what it looks to us when a polysubmarine like a spontaneous arousal may actually be a reflux episode. And this is an example. Look at the percentage of reflux events. Many of them do not produce an arousal. Many of them produce arousal. 62% produce arousal in stage 2, 14% in REM and stage 2, and 14.3% in REM. So clearly, these events are actually disturbing sleep, and this is one of the important symptoms I ask my patients about. Now, if we treat with nasal CPAP, there is a decrease in reflux. So again, why is this relevant? Primary care physician needs to know about it. And for us sleep physicians, this is actually something we know that they're responding to treatment. One of the metrics is that the reflux symptoms decrease. Another condition that is significantly affected and interacts with sleep apnea is type 2 diabetes. And this is a study from the University of Chicago, Dr. Tasadi. This is a very important study. They measured hemoglobin A1C in 60 consecutive patients with diabetes between 2007 and 2009. And on the y-axis you have hemoglobin A1C, and there are 4 categories of severity. So if you have no sleep disorder breathing, 5%, 5.5% or 6% that was the hemoglobin A1C. And you can see that hemoglobin A1C rises gradually with every level of severity. So people who have patients who have severe OSA, severe sleep apnea, have a significantly higher adjusted hemoglobin A1C. So again, this is one of the areas that we can actually make a difference. Type 2 diabetes improves diabetic control. How about kidney function? This is a study that looked at patients with end-stage kidney disease or actually chronic kidney disease. And they looked at the prevalence of the disease defined as more than 15 hours, 15 events per hour of sleep. And now these are the different categories. For example, this is those who have no apnea, then versus those who have chronic kidney disease, and then ESRD. Now those who have no apnea, the majority, these are the ones who had normal kidney function, above 60. You can see the majority did not have sleep apnea. A percentage had sleep apnea. When you have chronic kidney disease, you see that the numbers, this is the black bars, the percentage of patients with sleep apnea increases. And when you get ESRD, the numbers are actually very comparable. So clearly, end-stage kidney disease, advanced kidney disease, is associated with increased risk of sleep apnea. And if you look at nocturnal hypoxia, now people talk about hypoxic further, same story. As you get more advanced kidney disease, there is worsening in the magnitude of oxygenation. Now the diagnosis is truly, it starts with clinical features, with questionnaires, laboratory testing, whether you do a polysomnogram or you do a home sleep apnea testing. And that varies by country to country. And in the US, that varies from payer to payer. Medicare pays for polysomnography, whereas some other commercial insurance may not, and some Medicaid payers do not. Now, one of the clinical signs I like is actually looking at the chin. And this young man has retronasia. And with retronasia, you see that the chin is recessed compared to the nasion. The nasion is behind the nasion. And that means that the mandible is small and everything is crowded. Now, we also, in clinical evaluation, we look at what's called the Mallahaty score. I don't particularly find it useful if it's negative, but yes, it is, when you see it, it's consistent. Now, one other sign is actually neck circumference, which is probably the most powerful metric of the severity of the presence of disease. So for men who wear shirt size of 43 centimeters or more, that's their neck circumference, have 31% chance of having sleep apnea. So this is part of what we do in all of our clinical evaluation. We measure neck circumference. So the association between sleep disorder, breathing, and other conditions is very important. Now, the biggest one is hypertension. And this is from the Wisconsin Sleep Cohort Study, looking at the association between sleep apnea and hypertension. I direct you to the more than 15, because that's the one that's clinically significant. The black bar is adjusted just for baseline hypertension, and the gray bar is adjusted for a whole bunch of things, including baseline hypertension status, non-modifiable risk factors, BMI, weekly alcohol and cigarette use. And these were actually followed for a period of time. And you can see that those who have significant sleep apnea were more than twice as likely to have hypertension. So the presence of significant sleep apnea is a marker of the tendency to develop hypertension. For each 10 events per hour of AHI, blood pressure increases by 11%. This is actually a major association. Now there's this condition, shorter life. And this is an example from the Wisconsin Sleep Cohort Study. And what you will see, this is the different level of apnea-hypopnea index. This is AHI over 30, and you can see over an 18-year period, there is clear evidence of increased mortality. And again, it's a threefold increase in all-cause mortality. Now, there's another nationwide study, which is the Sleep Heart Study, which found exactly the same thing. Look at the red graph and show you the mortality in this population. Now, how do we treat it and why do we treat it? So, I'm going to pause for a minute and say, when we talk about treatment of sleep apnea, liberating from the disease, we talk about it the same way we discuss hypertension. Now, mind you, hypertension, we measure it exactly the same way, it's defined the same way. Whether hypertension is being measured in Cairo or measured in Detroit, it's exactly the same device, the same units. There's reproducibility, and there's more than 50 years of literature behind it. But sleep apnea isn't that way because there's so much variation in how we measure it. And even what we define as hypopnea is really variable. So it's important to note that. Now, one of the things we know about the treatment of sleep apnea is that it's actually, there is an association with decreased motor vehicle accidents. Again, the areas where there is consensus in the literature is decreased sleepiness, decreased motor vehicle accidents, improved quality of life. Another area that is actually likely to respond to the treatment of sleep disorder breathing is hypertension. I mentioned earlier that there is an association between sleep apnea and hypertension. And this is a systematic review in multiple studies starting 1996 to 2006. And if you look at this, and it's called the forest plot. So this vertical line, anything to the left, okay, meaning decrease, anything to the right, meaning increase. And after treatment, if you look at this forest plot, the majority showed a decrease. And now when you systolic BP is exactly the same thing. There is a decrease in blood pressure. And if you look at mean arterial pressure is exactly the same thing. So there is a consistent, systematic decrease in blood pressure with the treatment of CPAP. It looks small, but that's actually very compelling and very significant clinically. Well, what about cardiovascular events? Does really treatment of sleep apnea prevent cardiovascular events? And this is actually one of the most disappointing studies. This is the SAFE trial, which is a multi-national, multi-center study, but it looked at patients who had sleep apnea who were not sleepy, and that's the key point here. And when they looked, compared over an 84-month period, was there a change? Usual care is we did nothing, and then those who were treated with CPAP, and what you would see that there was absolutely no difference. Cumulative event curve of the primary endpoint showed absolutely no difference. Now the endpoint was death, myocardial infarction, stroke, hospitalization, unstable angina, or transient ischemic attack. So clearly they're saying treatment of sleep apnea is not affecting cardiovascular mortality. Now, there is another trial which is called the RICADSA trial. 244 patients followed 57 months, and it's exactly the same thing. We are unable to find a beneficial benefit. Now, one of the problems is PAP use is suboptimal. There was a signal of improvement if it's more than 4 hours per night. So again, the jury is still out on this one. Now, this is, instead of looking at one study at a time, let's look at an aggregate of studies. And this was a systematic review. And the same thing as I showed you before, these are all the different trials. And what you can see that there was no evidence that CPAP therapy improves cardiovascular outcome. Now the problem is there's always concern about risk of bias in these studies. Now I said earlier that treatment of sleep apnea is associated with improved daytime function. And what we're measuring here is sleepiness, subjective and objective. The subjective is with Epworth Sleepiness Scale, objective with MSLT, Multiple Sleep Intensity, and then the FOSS is the quality of life. And this one is looking at comparing the response by hours of use. As you can see here, that every one of these metrics had a different threshold. So for subjective sleepiness, the threshold of a plateau response was 4 hours. For MSLT was 6 hours. For quality of life was 7.5 hours. So if a patient asks, and I hear this quite a bit from my patient, how long should I use it? And I tell them, you need to use it the whole time you're sleeping. You need to sleep more than 7 hours, and you need to use the CPAP the whole time you are sleeping. And again, different use will have different impact. Any use is better than no use, from 2 hours and above, but again, you have to use it the whole time while you sleep. So with that, I'd like to summarize. Obesity rate have increased, and that increased the prevalence of the disease. Think of all the comorbid conditions, hypertension, type 2 diabetes, chronic kidney disease, reflux. I didn't talk about airway disease, but that's also another one. Snoring and hypersomnia have to be inquired about in clinical intake in all clinic patients. Not just sleep doctors, pulmonologists, primary care physician, family physician, general medicine physician, endocrinologist, neurologist. Everyone should be inquiring about snoring and hypersomnia in this population. And I always like to say, when actually you have patients who actually like it, here is a husband and wife, and I've had this picture for a long time, who are actually using the device every night. With that, I will stop and thank you for listening.
We'd like to thank Professor Safwan Badr for sharing his experience with us. Currently, Professor Safwan is traveling to the World Sleep Congress in Brazil, and that's why he recorded this presentation for us. Many thanks for Professor Safwan. And now we call for the end of this session, and we start the next session, Interventional Pulmonology 2. May I call the moderator of this panel discussion, Professor Nihad Osman, and the panelists, Professor Ahmed Youssef, Professor Ahmed Abdel Hafiz, and Professor Hamid Abdel Hafiz.